In cases of pancreatitis, severe pain is a primary concern. Administering prescribed opioid analgesics is crucial to manage pain and reduce stress response. While NG decompression and dietary changes are supportive, they are secondary to immediate pain management. For post-op patients with sudden chest pain, dyspnea, and hemoptysis, suspect pulmonary embolism first. These symptoms are classic indicators. Myocardial infarction and pneumothorax also cause chest pain but lack hemoptysis. Aspiration pneumonia develops gradually. In cirrhosis with confusion and elevated ammonia, administering lactulose is vital. This intervention reduces ammonia levels, addressing hepatic encephalopathy. Protein restriction can worsen nutrition, and sodium restriction targets ascites, not encephalopathy. For chronic kidney disease with pruritus and high phosphorus, administering phosphate binders is key. Hyperphosphatemia contributes to pruritus and bone disease. Phosphate binders reduce absorption, while dairy is high in phosphorus and protein management is secondary. In COPD, patients with high PaCO2 and low PaO2 encourage pursed lip breathing. This technique improves ventilation and gas exchange. Increasing oxygen can worsen CO2 retention, and supine positioning impairs breathing. For Addison's disease with hypotension and confusion, administer IV hydrocortisone immediately. Addisonian crisis requires corticosteroid replacement. Fluid restriction and potassium supplements can worsen the crisis. Continuous bubbling in a chest tube's water seal chamber indicates an air leak. Intermittent bubbling is expected with pneumothorax, but continuous bubbling requires assessment to address the air leak. For type 1 diabetes with diaphoresis and anxiety, provide orange juice. These symptoms suggest hypoglycemia, requiring immediate glucose replacement. Administering insulin would worsen the condition. In GI, bleed with low BP and high HR, start a 1L-NS bolus. The patient is likely in hypovolemic shock, and fluid resuscitation is the immediate priority to restore perfusion. For multiple sclerosis with bladder emptying issues, teach Creed's maneuver. This technique aids bladder emptying in neurogenic dysfunction. Anticholinergics can worsen retention, and permanent catheterization is not ideal. In sickle cell crisis with severe leg pain, administer IV opioids. Pain management is the priority, as vaso-occlusive pain is severe. Ice can worsen vasoconstriction, and hydration follows pain management. After thyroidectomy, hypocalcemia with tetany requires immediate action. This condition indicates parathyroid injury and can lead to life-threatening laryngeal spasm, making it a priority. Post-abdominal surgery, nausea, and absent bowel sounds suggest paralytic ileus. This condition results in absent or hypoactive bowel sounds, nausea, and distension, requiring attention. For patients on heparin therapy, low platelets indicate possible HIT, a serious complication. While APTT elevation is expected, low platelets are concerning and require immediate attention. In heart failure with rapid weight gain and dyspnea, administer IV furosemide. These symptoms indicate fluid overload, and diuretics provide immediate relief, addressing the primary concern. For myasthenia gravis with respiratory distress, prepare for intubation. Respiratory failure is the most life-threatening complication, making airway management a priority. In burn patients with low urine output, immediate intervention is required. Low output suggests inadequate fluid resuscitation, risking shock and kidney injury. Pain and edema are expected. For peritonitis with abdominal distension and fever, administer broad-spectrum antibiotics. Infection is life-threatening and requires immediate treatment. NG decompression and NPO are supportive. In Guillain-Barré syndrome with progressive weakness, prepare for mechanical ventilation. Ascending paralysis threatens respiratory muscles, and intubation prevents respiratory arrest. In end-stage liver disease with black tarry stools, assess blood pressure. Black stools suggest GI bleed, and assessing hemodynamic stability is crucial to prevent hypovolemic shock.